I'm happy now to bring up our next speaker, Dr. Laura Bogart. Dr. Bogart is a senior behavioral scientist at the RAND Corporation and a member of the Pardee RAND Graduate School faculty. She's a social psychologist specializing in CBPR to understand and address health disparities, and many of her research team, at least the domestic research team, is also here. Her primary interests are in the area of stigma and medical mistrust, and most of her research focuses on HIV prevention and treatment. I just want to say on a personal note that Dr. Bogart is somebody that I've known for many years. She's also often somebody I've turned to for professional advice, and whose leadership in many areas is one that I've worked to emulate and admire. And she's been a tremendous part of our planning committee. So I'm deeply grateful to her for that and look forward to her discussion about medical mistrust as it relates to HIV.
Thank you so much, Dr. Harawa, and also thank you, Dr. Bruce, for a fantastic talk. So today I'm going to be talking about the current state of research on medical mistrust in HIV and offering recommendations on how to proceed forward for providers and for communities. But first I wanted to start with a little bit about myself. I'm a social psychologist. I've been doing research on medical mistrust for about 20 years, mostly in LA communities, and also in other communities, for example, in sub-Saharan Africa. And a lot of what I present today is based on my own research and also some recommendations that I've thought about from reading the literature and the research literature in this area. But I'd like to acknowledge up front that I'm not from the communities that I'm working in. So what I try to do is engage with communities and stakeholders and engage with community partners as full and equal partners on the research. And I try to acknowledge the biases that I might have, both conscious and unconscious, and think through and acknowledge what might influence my research and the biases in my research. And I'd like to also mention that I work in close partnership here with APLA Health and Vienna Star. Oops. So first I want to acknowledge up front the collaborators on this research that I'm presenting today, which is more of a review of the research literature and recommendations. Oops. To the wrong slide. So Dr. Sai Takata and Dr. Billy Cunningham, both at UCLA, they're physicians and researchers in HIV. Dr. Takata, researchers HIV and social relationships. And Dr. Cunningham is a renowned scholar, internationally famous scholar in HIV and health disparities. So I'm very honored to work with both of them. So first, a note, a definition. So following from Dr. Bruce's talk, so what is medical mistrust? So it's distrust of healthcare systems, providers, and treatments. And more specifically, it's the absence of trust that providers and healthcare organizations genuinely care for patients' interests, are honest, practice confidentiality, and have the competence to produce the best achievable results. So people who mistrust healthcare might believe that physicians and researchers have ulterior motives, so they're only in it for themselves, maybe for their salary, for the glory, so for other things other than the patients. And also might think that there's harmful medical experimentation going on or unethical medical experimentation going on without their consent. So in the US, compared to all other races and ethnic groups, African Americans show the highest levels of medical mistrust. And it's, as we've just heard, thought to arise from current and ongoing discrimination. And I'll be talking more about that later in the talk, and we've already heard a bunch about that today. So one specific thing when we talk about HIV is HIV-specific or HIV-related medical mistrust. This is also called HIV conspiracy beliefs. And probably most of the research in the field of HIV and mistrust is focused on this area. So what are conspiracy beliefs? It's a specific form of medical mistrust related to the origin, prevention, and treatment of HIV. So, for example, HIV was created by the government, by the CIA, that antiretroviral treatment or ART is poison or not effective, or that there is a cure for HIV, but it's being withheld from the poor, so only the rich have access. I have a picture here of Magic Johnson, because that's a common belief that we hear in communities, that Magic Johnson has the cure, you know, because he's rich, he's famous, but everyone else can't get it. So, and actually, I wanted to just say one more thing about conspiracy beliefs, that one thing about them is sometimes people hear the word conspiracy and it has a negative connotation, but it's actually maybe just an effort to explain what's going on, explain a certain phenomena such as HIV, and powerful people who may be working behind the scenes and doing something unethical. So it means that HIV conspiracy beliefs are not necessarily false, harmful, or irrational. It's not something that only paranoid people believe. It could actually be a rational response to discrimination, what has gone on, the unethical medical experimentation and discrimination in society. So I've done several surveys of HIV conspiracy beliefs, and the first survey I did was a national random survey of African Americans in the US, and that was in 2002 to 2003. And so I found in that survey very high levels of these types of conspiracy beliefs. And so then I went back in 2016 and did a similar survey and looked at some of these beliefs again and saw, have they changed over time? So here I have the current state of what I found in the National Survey of African Americans. It's a general public sample. So the first belief, HIV is a man-made virus. In my first survey, I found that 48% endorse this belief. And now we found in this new survey about a third endorse the belief, so it's pretty substantial, but still went down over time. Also, there's a cure for HIV, but the government is withholding it from the poor. In the original survey, 53% endorse this belief, and here we find still substantial 40% are endorsing the belief. Now, two beliefs actually went up in mistrust. One is the medicine that doctors prescribe to treat HIV as poison. In the original survey, actually only 6% believe this, but now we're finding that about a third do. And I'm not sure why. It's something we can discuss after and maybe speculate. Maybe in the first survey, people hadn't really heard of the treatment and didn't know what they were talking about. And I'll at the end.
What year are you talking about?
Oh, this is the first year, 2002 to 2003. Yeah, and this is 2016. Yes, thanks. And then the final belief, the government usually tells the truth about major health issues like HIV/AIDS. So this is more of a trust belief. Do people believe that the government is telling the truth about public health? And in the original survey, actually 38% or 37% said the government is telling the truth. Here it went down to 18%. So less trust in the government over time. So looking at the literature on HIV and medical mistrust, this is what we find. So medical mistrust is related to HIV outcomes. So specifically to HIV prevention outcomes, we found that people who have higher medical mistrust or higher conspiracy beliefs are less likely to use condoms consistently. They're also less likely to feel comfortable discussing PrEP, bringing up PrEP with providers, don't know about PrEP, have lower intention to actually use PrEP, and then, not surprisingly, actually don't use PrEP as much. And in terms of treatment outcomes, several studies have found that people who have higher mistrust, both medical mistrust in general as well as specifically HIV conspiracy beliefs, are less likely to adhere to antiretroviral treatment. They're more likely to have detectable viral load as a result. And one study found that these beliefs about mistrust and medical mistrust in general may be associated with less likely to believe that the medications are effective, and that in turn is related to non-adherence to treatment. So together with Dr. Takata and Dr. Cunningham, who I mentioned first, we came up with a model of how mistrust might affect HIV outcomes. And it's called a multi-level perspective because we wanted to take into account the context of people within their social networks, within their communities, and within the larger society. So I'll be going through the model more specifically in the next few slides, but I'll show you the model up front. So at the very basic level is discrimination. So we've already talked about that and heard about that today. So both structural discrimination, so in society, so this could be laws that lead to disparities, such as maybe immigration laws or stop and frisk. It could be policies within healthcare organizations. For example, not to engage people of color when they're looking for people for clinical trials. It could also be society's societal stereotypes about people of color, about people living with HIV, and these negative stereotypes in turn may feed into interpersonal discrimination between people. So we can think of discrimination, it could be between a provider and patients, and it could be unconscious biases, it could be conscious. So these are things that in turn feed into medical mistrust, as we've discussed, and then in turn are related to HIV outcomes. And then one thing we talk about in the model is the different forces that may create, develop, and sustain mistrust over time and reinforce mistrust. So it could be at the individual level, coping and motivation, which I'll talk about in the next slide, the social level, one's social network and peer group, and finally at the structural level, one's leadership and one's communities. So we've already talked about this today and heard about this today, that discrimination leads to mistrust. That's at the most basic level in the model. And that mistrust stems from knowledge of current and historical injustices in healthcare and US society in general. So as Dr. Bruce said, it's not just Tuskegee, but that is a part of it. But there are so many instances of this, and it's historically, but it's also currently. And it's things we hear about from our friends and family, maybe things that people experience themselves, both within healthcare and outside of healthcare. So I had 3 bullet points here just to talk about some current research on the topic and some research on the topic. There's a lot more, but just to highlight, for example, just saying that one has experienced discrimination is also reported, related to reports of higher medical mistrust. So if you've experienced discrimination in general or in healthcare, you might mistrust healthcare in the future. Also, mistrust explains the association between discrimination and health behaviors. So, for example, if you're discriminated against, it may lead to mistrust, which in turn may lead to non-adherence to treatment. And this has been demonstrated in a couple studies. Some studies I've done with both Bienestar and APLA, we found this relationship where people with HIV are less likely to adhere to their HIV treatments. It's also been found in a study of Black MSM, finding that people are less likely to go to medical treatment or more likely to delay medical treatment if they've been discriminated against and experience mistrust as a result. There's also the last bullet, closer residence to Macon County, Alabama. Macon County is where Tuskegee is, where Tuskegee took place. Is related to more mistrust and lower healthcare utilization and greater mortality among Black men from before to after 1972. So Macon County is where Tuskegee took place, and then 1972 is when Tuskegee was revealed in the media, in the popular press, and people became aware of it, and the study ended. So Black men who had heard about this study and who lived closer to Tuskegee and maybe knew friends and family who'd been in the study were less likely to trust healthcare and less likely to go to healthcare as a result. So now I'd like to talk about what creates, how mistrust is developed, what creates mistrust. And also, as Dr. Bruce alluded to, mistrust can be a form of resilience. It's a protective and adaptive survival mechanism in the face of oppression. And of course, people are going to put their guard up if they've been oppressed and discriminated and mistreated. So it can be a healthy, functioning coping mechanism. So the point here is that mistrust is not necessarily harmful. A lot of times I hear people say, how can we reduce mistrust? What can we do about mistrust? And it's not necessarily wanting to get rid of mistrust. It's about addressing mistrust and channeling mistrust so that it's more healthy, a healthy form of coping versus leading to poor health behaviors. So also mistrust can spread in social networks. So people rely on social network members for healthcare advice, and especially in African American communities where their mistrust of the healthcare system may be high. People may experience a health problem and go first to their friends and family and say, you know, what's going on? I don't want to go to the doctor, so talk to other people in their communities. And they may hear from other community members, yeah, don't go to the doctor, you know, and also other high levels of mistrust. So social network members understand the content of discrimination, and that's why they're more credible. That's why you can go to them and trust them and not go to health care providers. So that's why people may do this. So I did a study with Charles Drew and APLA Health in which we looked at the social network of people living with HIV. And we asked people about their social network members and what they found, what they heard from their social network members. For example, did they hear beliefs about mistrust, mistrust related to HIV treatment, mistrust related to the origins of HIV? And we found that the more people heard from their social network members this mistrust around HIV and treatment, the less likely they were to adhere to their own treatment. This was African Americans living with HIV. So what it shows is that mistrust in one's social network can be a powerful force in one's healthcare behaviors. So mistrust can also be reinforced at the structural level. So, for example, among formal leaders, elected officials, religious leaders, informal popular opinion leaders also, such as musicians and artists, can be online as well as in person. And a particularly striking example of this is actually from South Africa, where in the early 2000s, then President Mbeki advanced conspiracy theories about HIV. That HIV doesn't lead to AIDS, that there are popular things such as beetroot can be used to cure HIV instead of taking Western medicine. And so as a result, he withheld treatment from people in the country. So the government is not going to support treatment. So one analysis found that from the year 2000 to 2005, when this was going on, this probably led to 330,000 deaths from HIV, as well as 35,000 children being born with HIV. So mistrust, when it's done by leaders, can have very strong effects. So just a few more slides. I know I don't have that much more time, but I just wanted to talk about how mistrust can be addressed. And so looking at the research literature, there actually are no evidence-based interventions, no interventions we know that work for providers to address medical mistrust. So I say this because when we started planning this conference, also we thought, you know, maybe it's something we can offer to providers when we talk about this. And looking at the literature, found there really isn't anything we know that works. So it's more of a call to action that we need to figure out what might work and what we can do about this. And there have been a few interventions done with providers, well, more than a few, but more about increasing cultural competency, empathy, and patient-centered communication. And these are not specific to HIV, usually for other diseases, but they also don't look at mistrust as a whole, medical mistrust in general. What they try to do is increasing trust in one's individual provider. And we find that a lot, actually, in research. We find that people say, yeah, sure, I trust my provider, but I'm not going to take those medications, they're poison. Or, no, I don't trust other providers. So what we want to do is find something that we can generalize, you know, across providers and figure out how can we have people do more than trust one individual provider. So there are a few patient-level interventions that I'm not going to talk about today, and hopefully in another community event I'll talk about them. But they're more about working with patients to decrease trust and address, decrease mistrust and address mistrust. So, for example, offering information and accurate information in a client-centered way. These are more like community-based interventions such as peer navigation, and where peers are serving as a bridge to healthcare and giving information and getting people into healthcare. So I'm offering a couple slides of recommendations. These are based on brainstorming with me and Dr. Takata, Dr. Cunningham, and I feel like this is a starting point for discussion today. It's not something I'm saying definitely needs to be done. I'd just love to hear your ideas about it. And one is to teach providers how to respond to mistrust in a sensitive manner while conveying accurate information. So when I started doing this research, I started by talking with providers and talking with patients and clients and saying, what happens when a client comes in and says something like a conspiracy theory, like that medication is poison, I'm never taking it. And providers sometimes would say to me, well, I don't know what to say. Sometimes I just say, well, that's not right, you should take it, it's good for you. Well, what we know is that telling people they're wrong doesn't really work. So we need to think about how do we talk to people, how do we offer information that might be useful to them and let them make the decision. And motivational interviewing is a counseling skill that's been taught to providers in many studies, and maybe several of you have had this skill. And it's where you learn empathy and reflective listening. So for example, saying back to the patient what the patient's saying to make sure they know you're listening to them and understanding what they're saying, not being judgmental or confrontational, offering information rather than giving information. Okay, I'll do 30 more seconds. and also, I think it's important at the same time to acknowledge the context, the historical and current context. Say, I'm aware why you feel this way. I know about this context of discrimination and the cause of this, and not dismissing people right off. And I'll just finish very briefly by saying a few recommendations for communities. And one is that I talked about how mistrust can be a healthy coping mechanism, and wanted to just say a little bit more about that, of how do we harness the positive effects of mistrust. And one, that mistrust can actually catalyze people to be informed healthcare consumers, to actually say, yeah, I mistrust healthcare, but I'm going to go around, I'm going to look up quality of care ratings, I'm going to figure out who's the best doctor in my area, and I'm going to do something about it if I can't find one. So thinking about, what can we do? Can we talk to healthcare organizations, encourage healthcare organizations to have community advisory boards if they don't, or talk to them about why this would be a benefit to them, if they're not able to get patients in or people aren't coming back in, and helping them review patient data, or do they have disparities that they don't know about. And finally, just a plug for voting and civic engagement. Mistrust, and this has been shown in research, can be of individuals to vote to make changes in their communities. And if one can't vote, to encourage others to vote. So thank you very much.
I don't like hearing my voice on this, but so my question is, so we're talking about research, and if anyone else has an answer, so how can are or should Black, African American, trans, non-binary, non-conforming, and intersex people be represented in research publications?
Thanks for your question. I just want to ask, do you mean as authors or participants?
Participants, like demographic breakdown, like, yeah.
So that's a great question, and I think we all need to think about how we can do that better. But basically, community engagement, this is something we've heard and that we've already talked about, talking about what would work, going out into the community, being genuine, talking about your study, not being afraid to go to everywhere in the community that you can think of where people are represented, and talk about the study, about the research genuinely.
I mean, like in the publications, though.
So Heather, do you mean like demographic tables or authors?
Yeah, like, data you presented, so like if that were to be broken down into gender, like how should trans people, non-binary people be broken down in research publications? Because in research, it's like very assigned male at birth, assigned female at birth, and yeah, I just am wondering.
Yeah, I have to be honest, I'm not sure I have the answer, but I think one thing to do is ask people how they would like to be categorized and actually put that in your study and put that in your publication, say this is how people identified, and not collapse categories. Not say, oh, we only have 2 people like this, so we're just gonna say they're other or something like that, which a lot of researchers do. So actually finding out how people want to be identified and saying it.
Thank you. Yeah, because I feel like a lot of surveys are very inclusive, more inclusive now than ever. But when it's published, it's published as something else. So I just was asking this room full of like people who are involved in health. Yeah. So if anyone else, I would love to hear that throughout some point today. Thank you.
Okay, thanks.
Hi. I just had a maybe rhetorical question to follow up on one of those statistics you brought up, that the belief that the government usually tells the truth about HIV went down. Do you think that that's actually an increase in distrust, or do you think it's maybe just that there's more information available about what happened in the 80s at the level of federal government?
I think that's a good hypothesis. I also think maybe trust in the government is going down in general, and because of the current context. So there could be a number of things.
Hi, my name is Raman. I'm the CEO of a technology company called Helvana. The question is, have you looked at being able to bridge the divide using technology in different ways, whether it's social media or ongoing communication with peers, using technology as the medium?
I have to say I have not used media as much as other people in this room maybe have, and other researchers. One reason is because a lot of the people who are participants in the studies that I do don't necessarily have access to media as much as other people. And so we don't always reach everybody. So.
Sorry, when you say media, you mean cell phones?
Yes, cell phones or, yes. But, and I know there are other forms of media.
Hi, it's me again.
Hi.
My question is, how do you assess the mistrust of the African American community, particularly in HIV research, without necessarily placing the burden of fixing the issue on the community itself?
That's a very good question, because I think sometimes when I present these statistics, people might take them the wrong way and think I'm placing the burden on the people who are answering the survey. So hopefully by providing a context such as this, and when we're talking about these kinds of statistics, we talk about them in the proper context, and we don't just present the statistics out just in one graph.
I actually have a question. I can speak louder. So, in terms of working with providers, I don't know how much work you've done, but what is their level of responsiveness to those, to doing things like motivational interviewing and what have you? Because that's a big part of it, right? Their openness to do something different in a clinical encounter.
Yes, thank you very much. So the question about openness of providers to actually making changes. I don't personally work with providers as much in my research. I work more with clients, although I have worked with providers in some research and actually tried to teach providers motivational interviewing. And sometimes I found, not to call out any specific provider, just saying my personal experiences with doctors and nurses, I've heard, well, that takes too much time to do motivational interviewing. I'm not going to do that. It sounds great, but it takes too much time. And what I've said is actually it doesn't take more time. It takes more time if you tell a person they're no and take this treatment and they don't take it. That takes more time. They keep coming back, they don't, and not taking the treatment. So and it's not helping either of you. So I think once people understand that it can help, I mean, I had providers have that initial reaction, and then some did try out the more motivational interviewing and said, no, you're right. I was able to persuade people to do things, to take the treatment, and I didn't realize that I could do that just by talking in a different way. So I think that that's just one message, is it doesn't take more time, but people have that perception right away. So thank you.
I feel like I've come to some of these so many times, and I do feel like the burden is always placed on the community or those of us who are of color and providers. As a clinician, I gotta tell you, when I have interns, I always tell them that, and I'm upfront, that I can't teach empathy. You can't teach empathy to a group of people with privilege in class. And so I'm wondering, when are we gonna turn the narrative and start teaching and calling out providers that, just like you just said, are unwilling to do motivational interviewing? So what else are providers gonna do? Because I always feel that the burden is placed on providers of color who probably have navigated through that mistrust and were utilized to engage and almost do the dirty work or the MI work. But when our providers, especially those who are white, are gonna be taught something else besides MI, because you really cannot teach empathy.
I think that's a great comment. I think also motivational interviewing is something that if people want to learn, they may want to try to learn empathy and try to be different. And it's more showing people, what happens if you don't do this? What happens with patients? Do you care about patients? And so I found that some people, it is harder to teach things like motivational interviewing, but it's not impossible if people have the motivation. So I agree that maybe you're saying some providers don't even have that motivation or that will. And I'd really ask other people to talk about what we should do about that, except that we can call out those providers, like you're saying. We can have people who know, this provider is better to go to than that one. And so we know who to go to, who's more empathetic, and we know who not to go to, and eventually those providers won't have as many patients.